Well, it's 12:15 and we're going to go ahead and get started. My name is Kim Schuler and I'm the CEO for the Arkansas Behavioral Health Integration Network. First, I want to thank you for taking your lunchtime to be here with us today. We know you're really busy and a lot's going on in the different health systems and spaces that you're working. So thank you for being here. And we're going to go ahead and get started. Next slide. We want to let you know that we do not have anything to disclose. We don't have any conflicts of interest. We also want to remind you that we are providing one CEU or CME for today's webinar. So please use this QR code, scan it. It'll take you to a link where you'll be able to access your CEU. If you have any trouble with that, don't hesitate to reach out to the ABIN team. We'd be more than happy to help you with that. Next slide. Okay, so we have a lot to cover today, but before we get started, we have a quick poll question. We know that this is the second of a series of 3 webinars, presentations on social determinants of health. Last year, we did 3 as well. And so when Justin asked us to do today's presentation, he asked for a behavioral health focus. And so as we get started with the poll, we have a quick question for you to introduce social determinants of mental health. So if you can take a minute and look at the question. It says, before today's session, I have heard of social determinants of health and social determinants of mental health, and I have a basic understanding of both concepts. I've heard of social determinants of health, but not social determinants of mental health. I've not heard of either concept. I've got this. Please give control of the screen to me. I can teach this session, and Caitlin and Kim can take a coffee break. Where am I? Can you please direct me back to my Amazon order? Want to start out with a little bit of fun and ask you to think about those different terms, and please choose the one that's most applicable to you right now. Jenny will share us the results as the answers come in. Give everybody a couple more seconds. What do we got, Jenny?
Are y'all able to see the percentages as they're rolling in? If
I am not.
Okay, we've got 133 people responded.
Woo!
47% said that they had heard of both concepts. 41% said they'd heard of social determinants of health, but not social determinants of mental health. 12% had heard of, had not heard of either concept. And one person would like control of the screen so that they can teach the session.
I'm okay with that.
Awesome. Wonderful. So please jump in and help us out, okay? Great. Okay, now we're going to go on to the presentation. We're going to talk to you today a little bit about social determinants of health. Go over a couple of those concepts again. We're going to talk a little bit about the mental health crisis in America. We know the pandemic really highlighted a lot of the mental health issues, behavioral health issues that people are facing, and brought it to the forefront of really being a true mental health crisis and helping identify the need to put more resources into addressing the mental health components. We're going to talk about the social determinants of mental health, and we're going to talk about how to address this in primary care and in health settings, as well as look at a couple of case examples for social determinants of mental health, and then call to action. What can we really do to address social determinants of health and social determinants of mental health in Arkansas? Next slide. So we're going to start with a video. And this is a nice video that talks a little bit about social determinants of health and also ties to the mental health, the behavioral health components. So we're going to take a brief moment and watch this. I don't have any sound, Jenny.
I was worried about that. I think I have to share my sound when I share the screen. Let me see what I missed. Share. Share sound. I'm so sorry. Here we go. We should be good now. Okay.
Even before we're born, there are factors at play which influence our health and well-being. The conditions in which we're born, grow and live can affect us and our health in different ways. We also react to them in different ways. Poverty, stress, lack of adequate housing, education, unemployment and poor access to transport and nutritious food are some of the things that can affect our health and life expectancy. The World Health Organization recognises that health and well-being are strongly influenced by social, economic and environmental factors known as the social determinants of health. The environments in which we are born, grow, live, work and age can have stronger influences on our health than our genetic, family history or behavioural risk factors. A person's social and economic circumstances affect their health throughout their life. The relationship between income and health is on a gradient. This social gradient means that even a little bit of wealth can increase your likelihood of being healthier. A stable source of healthy food, appropriate, affordable and secure housing, education and employment, relief from financial distress, access to transport and services, loving and stable relationships, and being able to make choices about our lives means we are less likely to experience chronic conditions such as diabetes, cardiovascular disease, depression, anxiety, and other mental illness. How we are treated by and interact with others also has a huge impact. Stressful circumstances over a long time that make people feel anxious or unable to cope, discrimination, racism, social isolation, or just being treated as less than equal can lead to poor health. And the interplay between these factors and a person's socio-economic circumstances can compound the situation. Experiencing a lot of stress and feeling unable to change things can also lead to poor health. But as health clinicians, there are things that we can do to make a difference. Look beyond the illness to see the whole person and try to understand the reality of their daily situation. Ask them what they think would make a difference to their lives and really listen. It may be that taking care of their health in the way you suggest won't be easy. It may make things more stressful for them, so try and see what other support you can offer. Advocate with them and give them knowledge on where to turn for help. Offer transport options for people to come to your service. Consider food vouchers to families who are struggling, or talking to nutritionists who can work with people to cook a healthy meal on limited income. Offer education about making better lifestyle choices to encourage healthy eating. But remember that all the advice on good nutrition will be a challenge if people are living on a limited budget. Offer medications for longer periods of time for people who can't get to a pharmacy easily, and refer people to other services like counselling or housing assistance. Help improve their health literacy by encouraging and working with them to better understand their illness and be more active in their own health care. Even one small action, like really listening and being compassionate, can go a long way to improving their health. Changing your practice, even ever so slightly, might mean the world of difference to someone.
Okay. Thank you all for watching that. Is there an echo?
I'm not hearing one.
Okay.
Yes, I hear an echo.
Thank you, Misty. All right. Excuse me. Thank you all for hanging in there, watching that video with us. Awesome. Thanks for your response. I appreciate that. You know how it goes with technology, managing all these different components. We appreciate you hanging in there with us with the video and then with the echoing, and we're going to get rolling. So as we talked about, there is a mental health crisis in America. The pandemic really highlighted this. We know that we've got some stats up here for you. You can see over 59 million adults, 18 and older, had a mental illness in the past year. Nearly half of them didn't receive any treatment. We see 15 million adults reported having a serious mental illness in the past year, but about a third of those with a serious mental illness didn't receive any treatment. We also want to highlight, and I think it's really important, that under the behavioral health umbrella is substance use disorders. For people who are struggling with substance use disorders in the US, they're 15.35% struggling. 93.5% of those individuals didn't receive any form of treatment for that substance use disorder. So that tells you lots of people are struggling with mental health issues and they're not getting treatment for it. It could be that it's not been identified, they're not reporting when they're coming into their healthcare providers, and they're not seeking out services. There might be a lack of services. They might not be able to access mental health services easily in their communities. So there's a whole host of reasons. Next slide. We know that not treating that mental health component is really costing us a lot on our health system. And it's a burden all around, all across the health system. When we're thinking about social determinants of health and the cost, we can see escalating cost and increased utilization because of the social determinants of health or the social determinants of mental health. About $3.6 trillion in expenditures annually, according to CMS. More than 50% of hospital readmissions are due to this. Approximately $200 billion in premature deaths. We also see inadequate chronic illness management, about 4.3 million in preventable emergency department visits, 30% of unnecessary visits, and 86% of the chronic health spending overall. So when we saw those statistics, we thought this is really important, and it's important for us to know that this is causing an extreme cost burden to our health system. Next slide. So the cost of unmet mental health. You could see on average, if a patient comes to the emergency room and they have behavioral health needs, these visits can cost up to more than $2,264 per visit. We know there's a lot of inequities with marginalized and underserved populations. We see racial and ethnic minority groups are struggling to access mental health care or community mental health. Often patients with unmet health needs are more likely to obtain care from emergency departments. And the care is often for acute symptoms. They're coming in because something's happening right now and they're wanting immediate assistance, but we're not really getting to the root of the problem. Next slide. This slide can demonstrate the increased cost for some of these chronic diseases. I think it's really important if we looked specifically at asthma, you could see the cost to treat asthma in orange, which is $9,810. There's a 29% increase if there's a behavioral health condition associated with that asthma diagnosis. And you could see the cost goes up 141%. So it's really important for us to be aware that there is increased cost. And when we're thinking about social determinants of health and social determinants of mental health, that mental health component can really affect and really become challenging when we're trying to meet the health needs. Next slide. I think this is really important. This just came out in JAMA, this graphic, and there's a little article. It came out May 23rd. So I thought it was really relevant because when we're thinking about what are some of the drivers in the mental health crisis and how are we going to address mental health and the social determinants of mental health components and how is it related? We're looking at social determinants of mental health, but we're thinking about things such as our lifestyle, where do we live? Are we social? Who are we socializing with? Are we socializing in healthy ways? Are these positive, energizing relationships? And in the JAMA article, they talk about loneliness and really identify loneliness can increase the risk of heart disease, dementia, stroke, anxiety, and depression. And so wanted to highlight this because these are really concerns and it's important for us to know that really the social components of our life are really affecting our physical health. Next slide. Now I'm going to turn it over to Caitlin Johnson. Caitlin, please introduce yourself, and she's going to take over the next set of slides.
Okay. I'm Caitlin Johnson. I'm an LCSW. I'm based here in Central Arkansas, but I do remote project management for AVEN. And my background's been in various levels of integrated health throughout my stint in healthcare. So I see a couple of my previous coworkers on the call, and I'm sure it will not be surprising to them that I am speaking about SDOH because it's something that they have had to hear at length about when working with me. So I'm sure it's not surprising. But I'm going to go ahead and tell a little bit more about social determinants of health itself. I talk very fast. I just get very passionate about what I'm saying. If I need to repeat something, or if you have a question about what I said, please put it in the chat, or we can come to it at the end of the webinar. Just like to give that preface there. Okay, so when we're looking a little bit more advanced into the social determinants of health, we want to review the question of how do our socioeconomic statuses affect or rather influence our health. And we thought this was an interesting chart to share because you can see just how much these different sectors affect our health. And the biggest part of these health influences are going to be our socioeconomic factors, our community and our safety within that community, our employment and our subsequent income, our access to education. But the second biggest part of that chart is going to be our health behaviors. And those socioeconomic factors are going to affect how we can interact with and perform certain health behaviors. So if we thought it was important to point out that, yes, your education, where you're born, your access to equitable health care influence your ability to engage in health behaviors. But another thing that we wanted to point out there is how, I mean, it's still a big chunk, but how much smaller that clinical care piece is in this entire wheel. Because we need to recognize that these problems, these SDOH needs, are bigger than just the clinical care space, and that we have a role to play in it, but it's not just the clinical health team, it's everyone. It's the community, it's our government, it's our health systems as well. Next slide. So the video, I feel, did a pretty good job on explaining the different types of social determinants. So I don't want to necessarily spend so much time here, because we do have other webinars in this series that go a little bit more in depth with the SDOH, and we're going to talk about SDOMH today. But I just wanted to show the broken down pieces of this chart. There's education, there's healthcare, neighborhood and your environment, social community context, and economic stability. And it's important to note that each one of these sections on this chart are umbrellas, right? There's a lot of things that fit underneath that education section. So whether or not they have a safe high school to attend, do they have access to to higher education, whether that is financially or geographically? Do they have an adequate understanding of their healthcare, that health literacy piece of it? And then speaking of healthcare, do they have equitable healthcare? Not just are you able to access it, but do these health systems employ people who understand what I'm going through and are able to educate me on these specific disease processes as it relates to my environment and my culture? Next slide. So just to illustrate this a little bit more, we have a couple of charts that'll show correlations between SDOH and our healthcare, our health outcomes rather. So the Office of Healthy Opportunity released this study in this year, showing that there's a direct correlation between education and health outcomes. And you can see here that people with less than a high school education have a higher instance of reporting less than very good health. And I don't know what their qualification was for very good health. I don't know if I know someone who's in super very good health these days, but I mean, this makes sense though, right? So with more access to education, typically you get a better paying job. Better paying job gives you more income. That gives you better access to healthcare, and usually better benefits to access that healthcare with. So with more access to education comes the ability to interact with your healthcare team more frequently and more at 100% as opposed to the 50%. Next slide. I don't think this is going to be a surprising thing to anyone on this call on how this impacts these SDOH needs impact our mental health. People who are living below that federal poverty line are more likely to experience worry, nervousness, or anxiety. Of course, if my basic needs are not being met, if I don't feel safe in my house, if I can't afford food, if I can't, I don't know how to emotionally regulate because I had a really tough childhood, of course I'm going to be nervous, right? That makes a lot of sense. Next slide. Again, just an illustration on how income affects mental health. On this study, it was done in 2007, but the World Health Organization referenced it in 2014 as proof that as household income decreases, mental health, common mental health disorder diagnoses increases. And that could be a multitude of things. The biggest thing being, well, they may not have the money to engage in preventative care for these types of diagnoses. Next slide. And then finally, suicide rates depending on geographical location. So we see on this, and hopefully you can see the key up there in the left corner up there. As people become more rural, as you get into more rural settings, that top dashed line shows non-metropolitan suicide rates for patients that are living in a non-metro area. And considering this chart, I mean, if we think of it as a multitude of things, people who live in metro areas have a little bit more of an access to public transportation, or at least the infrastructure for one. They have access to more community engagement. Typically, depending on the city, you have more walkable sidewalks, you have a walkable community. And as we get more rural, much like Arkansas, over 40% of the state is rural, you see an increase in suicide rates because they don't have the opportunity to engage with that social support system as much or access healthcare due to location. Next slide. I'm gonna hand it back over to Cam to go over now. How are we marrying SDOH and SDOMH?
Thank you, Caitlin. And thank you for talking about social determinants of health and really level setting the importance. So Caitlin talked a little bit about social determinants of health. We're now going to talk more about social determinants of health, because ultimately this is what we need to address in order to achieve whole person care. You can see our quote here: the more nuanced factors that influence an individual's emotional and psychiatric well-being are known as social determinants of mental health. So now we're going to talk a little bit more about that. So when we think about types of social determinants of health and what affects social determinants of health, I think it's really important for us to know some of these crossover, and they're not exclusively to SDOMH. We see them in both SDOH and SDOMH. However, some of them are different. So poverty, it's important to know, as Caitlin talked about, poverty can definitely affect our health. Racism, sexism, homophobia, and other forms of social exclusion, discrimination is someone living in an environment where they feel that they're being discriminated against. It's a stressful situation. It's a toxic situation. They don't feel safe. Safe and secure housing. It's important for us to think about when someone is leaving their home. Do they feel safe? Do they feel comfortable going outside, walking around in their neighborhood, engaging in their community? Adequate and nutritious food. We'll talk a little bit more about that. We have a case example talking about food. Can someone access quality health care? Maternal health and services, educational inequality. We've talked about, is it stressful if I go into my school and I have to walk through a metal detector before I can get inside my school? I don't know, that might make me a lot more nervous when I hear my kids talk about some of the things that they face in a public high school. That's challenging, but that can definitely cause stress. It can cause anxiety if we don't feel safe in our surroundings. Environmental pollution and climate change. We're going to talk a little bit more about this in a case example, but I think it's really important to know if we live in an area where, as we know, there could be environmental changes. We just had tornadoes that have happened last weekend in Arkansas. Last spring, we saw tornadoes in the metro central area of Arkansas. These are really significant. These can cause significant anxiety. They can cause stress. People can have mental health symptoms and challenges as a result of being in these environments. And then adverse childhood experiences, this directly correlates with an individual's health. Next slide. This slide has a lot of information on it, but we thought it was a really nice illustration of social determinants of health. And really, what are social determinants of health? And as you can see, there are a lot of different areas that affect and contribute to someone's mental health. Childhood maltreatment, discrimination, education inequality, unemployment, housing, we see air pollution, climate, poverty, poor diet, The result of these are often reduced choices. It might be much easier for me to go to the grocery store that's in my community, and they may not have a wide variety of nutritious foods. Behavioral risk. I might be engaging in smoking, using tobacco, alcohol, misusing substances. It can cause physical stress, psychological stress or distress, and poor mental health. One of the things that we saw, and this is interesting, I've not seen this, a medical sociologist talked about health as social. And so wanted to add this as something for us to think about as we're starting to think about social determinants of mental health. Next slide.
So food insecurity was one of the examples that Kim gave, and we know that cross references with SDOH. However, to talk about it in a mental health context, we wanted to bring up what food insecurity can do, how it affects the family unit. So we know that not having access to nutritious food, it can cause diabetes and obesity and heart disease, but also mental health disorders. We know that there's a study done that showed in 2020, 15% of the US households, which personally during that year, it's probably a bit more. I feel like 15 maybe a little low for 2020, but 15% of the US households were considered food insecure at one point, and half of those households included children. And what we know is when children do not have access to nutritious food or food security, it affects their development, especially in that early stage, and then subsequently affects their school performance and experience, which goes on to equate to the slide that we talked about with lack of education or lack of being able to engage in education as much as they would like to. Next slide. So this one was pretty unique to SDOMH. I'm sure there's a lot of moms on the call and know how difficult it is to juggle your child's schedule, your child's care, while trying to engage in your own health care. And one of the studies that was actually for both of these points, the studies done in 2023 showed that women are 3 times more likely than men to not engage in their health care because they do not have child care, whether that's through support or through daycare. And then you add the fact of living below the federal poverty line to that, it decreases that amount once more, and they come in more infrequently then because they just took the income aspect out of it, and they can't afford daycare, let alone find a family member who's probably working as well to watch that child as they go and take care of their own health. On the flip side of that conversation, though, the Harris poll does show that when women are able to access childcare, their health improves, their mental health improves by 40%. So that is such a huge jump in that statistic that I'm glad we're having this conversation because it needs to be addressed. Jenny, next slide, please. Oh, and I forgot on that last slide. We do have I'm going to shamelessly plug here. We do have a podcast series that we recently released, and we have 2 episodes that are coming out on maternal mental health that we interviewed 2 Arkansas-based clinicians on. And we should be releasing those hopefully in the next week. We do currently already have an episode up on pure specialist and stigma associated with that profession. All of those episodes are eligible for 1 CEU each. They're an hour long, and we can put the podcast link in there, and hopefully we will have the maternal mental health episodes published in the next week or so. I just felt like it went really well with this conversation. Okay, Jenny, I'm ready. Sorry. Okay, and then housing. Additionally, we know that we all need safe housing, but what does it do to our mental health? Well, a study showed that children that were living in public housing would their mental health outcomes were better than those on the waiting list. That makes a lot of sense, right? And if you live in Central Arkansas, you know that our housing authority right now only has certain windows of time that they're open to accepting applications. The wait time is several years long. So this just goes to show that unsafe housing or no housing at all obviously affects mental health outcomes. However, there was a Healthy Beginnings at Home model introduced in Ohio that showed perinatal women with a behavioral health condition diagnosed. They received housing intervention, and it showed not only an improvement in their health, but also the infant's health. So access to safe housing improves not only mom's health, but also infant's health. And then finally, the housing first model. I'm not sure if you guys are familiar with that, but it's like a rapid housing first, house these individuals first on the list, then we will take care of the other things that they need, because it is such a significant thing that affects their mental health. There are some models that have been introduced in other states, but Arkansas is still finding their footing with this. We do have some initiatives that are going on, and we'll talk towards the end of the webinar a little bit more, but just for a brief reference, Providence Park, they just broke ground here in Central Arkansas. That is a tiny home community that should be used, that will be used as a rapid housing situation. Homes program in McCauley Place, that's up in Northwest Arkansas. That is where they are providing housing support for their teachers. And then Cobblestone Farms is another tiny house initiative that's also in Northwest. Next slide. Okay, another poll here. Interested to see who's out in the audience and what you're seeing most in your practice. Jenny, I'm gonna let you run that. We'll just take, just to stay on time, probably about 30 seconds for these responses.
All right, we've hit the 30-second mark. I'm going to give 3 more seconds. And
I'm seeing safe and secure housing and adequate food battling it out in in the poll there.
So can you see the results? I shared them.
Absolutely. And Chad, thank you for putting in the chat. Transportation is not on the list. And yes, transportation is not on here. We appreciate that.
Okay, and boy, if you know me, transportation's on my list, I'll tell you that much. So funny that it's not on there. Okay, I feel like this is a really important part of the webinar, so I'm going to try to get as much as I can in within our time frame, because we definitely want to leave time for questions in that. So I apologize if I'm talking a little fast. So as we talked about in previous slides, there is a responsibility on the clinical team, on the healthcare team, to address some of these things. And when I'm seeing a patient, and I'm sure how most of you are seeing a patient, when they come in and they are asking for help, or we're looking at their treatment team, we're asking ourselves, how well are they functioning? Are we helping them function to the top of their ability? Are they able to engage in their care? Are they able to balance their life stressors and their responsibilities? Are they getting quality interactions with their family and their community support systems? And how well are they bouncing back from life stressors, to like an argument at work all the way to having a divorce? Do they have that neuroplasticity that allows them to approach a problem and then be able to adapt from it? And as we go through these slides, you'll see that we're talking from a primary care perspective, because we are the integrated health network. But this is appropriate across the healthcare continuum, whether you're in inpatient or you're in a rehab, substance use or physical, or if you're in a specialty clinic, these are still valid things that you can implement in your clinical care. Next slide. Okay, so the first thing that we can do is screen. And I know, I'm sure most of you on this call are tired of hearing the word screen. We screen for lots of things, and I hear you. I've been there. My previous job was based a whole lot on screeners, so I know there's frustration with it. However, for us to make sustainable change, we have to be able to look at this from a systems level and access the data that'll let us advocate for more funding, let us advocate for more for program development and expansion. So I know sometimes it is frustrating to add yet another screener on, but there's reasons for this. And there's 3 tools that the AAFP suggests. I'm not going to click on them just for the interest of time. You will get these slides for sure. And these are hyperlinks, so you can click right on those. But there are 2 that you can implement in your rooming, or you can use number 3, which is self-administered, which I know a lot of clinics like. So that is available for you guys to review. I am seeing it, in the chat. We will send these out. You will have access to this. Next slide, Jenny.
I also wanted to say on the Everyone project that is available in 7 languages on the AAFP's website, and they have fantastic resources there.
Yes, and so you can get paid for it, and I added an asterisk, so there's not rioting in the streets. Yes, you can get paid for it, but under certain circumstances. So over here on the left, you see a screenshot from the CMS 2024 physician fee schedule. They have authorized a G code to where you can bill for these screeners during specific times. I'm not going to go over that because we also have over on the right side a fantastic presentation done by Blue Cross Blue Shield and the Arkansas Rural Health Partnership that was done last year that can also explain Z codes in this context as well. And that will be made available to you to review. So yes, you can get paid for it. Maybe not in every instance, still worth doing. Next slide. Okay, so we can't just rely on screeners all of the time. We know that. And there may be instances where they come in for their annual wellness visits, these patients do, and maybe they just don't feel like sharing that they had a really tough childhood. Or maybe they don't feel like sharing, hey, I can't pay my light bill, and it's really making me anxious. Maybe they just don't have the capacity to share, or maybe they don't view this as a safe place to do so yet. So there's going to be instances where patients are going to come in with ambiguous symptoms, and it's going to be important to ask, hey, how is everything going at home? Are there things that you need that you're not getting right now? And do you think maybe that can be causing some of these symptoms? Because as we meet with these patients, we have to understand that they're often coming in and looking at their healthcare through different lenses than we are. Okay, so oftentimes, we may say, hey, you really need to stop smoking cigarettes because it's bad for your health. The way that they're looking at it is, this is the only way I'm able to function day to day because my kids stress me out or my job stresses me out, and this is what keeps me functioning. Or the argument of, here, let's start a sleep med, and the patient isn't sleeping well because they're having night terrors from past trauma, right? And we're not necessarily engaging and asking what's causing all of these things. We're just treating the symptoms instead of looking at functionality. And then, it's just really hard to argue with a patient about taking your lisinopril when they are not able to they're not meeting their basic needs. They're not able to meet their basic needs. And that kind of goes along with Maslow's hierarchy. I'm sure this isn't new to anyone on this call, but the bottom 2 levels of this pyramid, your physiological and your safety needs, if those are not met, you're going to be anxious. You're not going to feel safe. There's going to be chronic stress on you to achieve those things until they happen. And coming in and talking to your doctor can sometimes be frustrating because you don't know if you can talk to them about those types of things. One of the things I wanted to point out here on what stress does to the brain, and I am spending a little extra time on this slide because as a healthcare agent, we have to recognize that these patients are probably coming in survival mode. And what survival mode, prolonged survival mode, and chronic stress can do to the body is just completely wreak havoc on how our body responds to stress. It can cause anxiety, it can cause GI issues, it can cause high blood pressure and chronic pain. There's a lot of autoimmune disorders that come with not having SDOH needs met, and that chronic stress response going through your body. So these effects, even if, let's say, that chronic stress is going on between 20 and 30 years old of a patient, and it gets resolved, those things can still affect that patient at 50 to 60 to 70 years of age because they had a prolonged experience with stress and had overexposure to cortisol and other stress hormones that affects the patient's body's ability to fight off infections and to fight off some of these other diagnoses. So as we see these patients with possible multi-generational trauma, with chronic stressors, with high ACE scores, We do need to empathize and take a look at how they're viewing their healthcare and what they feel like they're able to do in the moment. And that means doing those screeners, but also knowing when to ask outside of the screeners. And by doing so and bringing up that conversation, you're taking responsibility and saying, I'm decreasing stigma associated with SDOH or SDOMH. I'm making myself a safe person for you to talk to, and I'm increasing rapport and letting you know that you can talk to us about these things. Next slide. How do we do this? How do we increase stress tolerance? There's a couple of things. Again, you'll get these slides. You can click on these links. One of the first things you can do is implement SMART goals with your patients that include SDOH. Okay, so if you're referring to the SNAP hotline, if you are referring to the health literacy center or something like that, include that in the SMART goals. So it's not just take your blood pressure medicine. Let's also make sure we call that hotline by such and such date. And these are the steps that we'll take to do it. Psychoeducation is another part of it. Normalizing this. Of course, you don't feel good. Of course, you can't take your blood pressure medicine. You're just trying to figure out how to keep your lights on. I think it really empowers a patient to know that what they're going through is normal. And one of the ways that you can do that with psychoeducation is letting them know, hey, I know that you're going through this. Let's increase your stress tolerance by talking about something like sleep hygiene. And then finally, a patient-centered approach. We want to move from don't talk about it if we don't have an answer for it, which was my mentality really early on, was how fair is it for me to ask about these things if I don't have an answer for it, and move to, hey, did you know that if you experience a food insecurity, it makes it more difficult to manage your bipolar disorder, and provide that patient an opportunity to discuss the hardships that come with that diagnosis and SDOH needs. Next slide. Okay. Integrating a closed loop referral service. When you make a referral to community resources, making sure you follow your staff follows up on that. We typically want to do a closed loop referral for specialty. If I'm referred to GI, my PCP is going to call, make sure I went to GI. We need to do that with community resources as well, because that's just as important, just as an important piece of your healthcare as taking a medication or seeing another specialist. Next slide. There are everyone on the care team has a role to play in this, from the front desk to the clinic manager. The front desk is able to tell the rooming nurse how that patient presented in the room, kind of give them a heads, or in the waiting room, give them a heads up. The rooming nurse will be able to do screeners. The provider will engage in that SMART goal development as well as the BHC if you've got one, and a care coordinator can also work on those SMART goals with them and make referrals to community resources. And the clinic manager can implement workflows that support these screeners and these referral networks. Additionally, we want to introduce a multidisciplinary workforce where we're using our community health workers and peer support specialists out in the community. We understand that burnout can happen with unmet SDOH needs. As the healthcare agent, it's really frustrating to try to do a job that you don't have the tools for often, but relying on other disciplines to help with that. Community health workers may be a little harder to find right now, but peer support specialists are all over the state. We do have a website that you can look up the directory and be able to see where your nearest peer support specialist is for substance use disorder patients. Next slide. All right, Kim, just in the effort of time, do you want to go over these examples, or we got about 10 minutes left?
Yeah, Jenny, if you can go to the next slide, I'll just quickly go over the next one really quickly. Here's a good example of, as I was listening to Caitlin and listening to her talk about how to meet the patient where they are and how to support them. This is a good example. This patient's coming in and they have been diagnosed with chronic renal failure. They're receiving dialysis 3 times a week. Attending dialysis 3 times a week, it's really taking a toll on them. It's exhausting. It's difficult for them to go to work and maintain their energy level so that they can work. That struggles in missing work and not making as much money. They're not able to follow the recommended treatments. They don't have the energy to follow the special renal diet, to do some of the exercise that's recommended. And they're starting to feel increasingly depressed. They live in a commuter community with limited access to sidewalks or reliable transportation. We talked about they don't have the ability to work, so they're struggling financially. Often they're having a nighttime beer or cocktail to try to ease their pain and really help them with their stress. We know alcohol can be a depressant, and this is further deteriorating the patient's mental health as well as their physical health. The reality, we're seeing increased depression, and we're seeing decreased health outcomes. Some of the things that we can do about this are psychoeducation, talking to them about social determinants of mental health, how this is affecting their overall health, increasing contacts for this patient, at least initially, while we're trying to stabilize them and meet some of those social determinants of health needs. So have higher touches with the care manager, developing SMART goals into the treatment plan, coordinating transportation, referral to SNAP hotline, and using that closed loop referral process. Next slide. So one of the things that we know when we're working with patients who are struggling with social determinants of mental health is it takes a lot of energy. It can be exhausting. As Caitlin mentioned, there's often not enough resources. And oftentimes when we're working with patients, it can be really frustrating because we're in the helping profession and we want to help those patients and we want to try to connect them to the services they need, but they're just not available. So it's really important for us to be aware of what we can do and making sure that this is a team effort. So we're communicating with our team, we're leaning on our team, and we know that they might have information or access about what kinds of resources that are in their community. I'm gonna move quick just for the sake of time. Next slide. Okay. As a clinician, part of a healthcare staff, information about SDOH makes me feel. Let's take 15 seconds. I know we're all quick. Empowered, concerned, overwhelmed, confused, undercaffeinated, help I'm drowning. Jenny, any results?
Yes, 43% say empowered, 32% say concerned, and 23% say overwhelmed. 2% are drowning.
All right. Thank you. Next slide.
I think it's normal to feel all of those at one time. So you can feel motivated, but also scared and overwhelmed. And so no judgment here.
Absolutely. Absolutely. Okay, I'm looking at the clock. So I think it's really important for us. There are lots of things that we can do to start addressing social determinants of health in our health settings. One of the things that's really important is to start screening and data collection. Looking at what kinds of mental health services are available in our communities. Provide SDOH training for the entire mental health workforce. Lots of times, just because we're working in the mental health space doesn't mean we're really aware about these SDOH needs. And we need to have cultural and linguistically appropriate services. Next slide. Okay. So here we can see increased research is needed, collaborate with other advocates, support programs. One of the things that I think is really important, and I just want to say, oftentimes when we're thinking about, well, patients are coming in and we might be able to help connect them to resources. One of the most important things that we can do is really compassionately engage with our patients, listen to them, and at that point, learn specifically what is their story, what do they need, and at that point, try to connect them to some of these resources. Next slide. some things that are happening in Arkansas and nationally, and I think it's important. There's a lot of work right now happening on behavioral health integration. We see that CMS has an innovation program in behavioral health. There are funding opportunities. We're looking at more support of payment for telehealth services so we could reach people maybe in rural areas or people who are at home through telehealth services because they don't have access to transportation. Next slide. Some of the cool things that I think are happening in Arkansas, there's a lot of programs out there. We know AR Connect is the program. If someone is struggling with accessing mental health services, that is a telehealth-based model through UAMS. Connecting with the literacy center. So we're making sure we're getting out the health information that is linguistically appropriate, easy to understand. One of the things that I'm sure this happens, when I go in sometimes to my healthcare provider, they give me information that's wonderful, but sometimes it's challenging to understand. Housing, we need to have more of these housing efforts. We know that some cool things are happening, as Caitlin mentioned, and we see communities coming together, and the communities are talking about social determinants of health and how do we address these social determinants of health and mental health, and they're starting to develop plans. One of the things that I think is really, really cool, as we were researching, I didn't know this, the American Psychiatric Association, they actually have a task force. The president asked to have a specific task force, and they have been meeting. They're working on a plan to address social determinants of mental health. And they are coming up with some different workflows. And I think that that's really important. We also know that some cool things are happening in Arkansas. There is a social determinant of health work group. Justin Valians is our leader for that work group, but we have representatives from all different sectors who are coming together and bringing ideas, talking about what are specifically the social determinants of health needs in their community and how can we problem solve and plan together. Another piece of this is to know your local community resources. We know that every community is different and there are different amounts or different community resources. So we need to know, where are the food pantries? Are there free health clinics? Are there transportation options available? And how do I access those? We know that there is a Healthy Steps program that's looking at screening and addressing maternal health. We know if we could support children, infants, and babies early on, we can avoid a lot of the mental health issues and a lot of the long-term struggles that they could face. Some cool things that are also happening. There is a collaborative care model grant that's happening. AFMC has a grant where they're putting community and school programs, and they're specifically addressing the social determinants of health needs for students in those rural programs. So just wanted to put a shout out. There are things happening. We have a lot of work to do, but there's also really cool programs. Someone put in 2-in-1 in the chat. Absolutely. That's a statewide referral network. HARC is happening in Northwest Arkansas. There's Find Help. So please know that there are a lot of ways to access these resources, but want to just reiterate, I think sometimes when patients are coming in, and I think about myself, I don't remember, I'm not remembering and I'm not thinking about, here I am in my doctor's office and I can talk to them about a social determinant of health that I'm struggling with. Patients may not realize they can talk about, I'm really struggling with food insecurity, or I just lost my job and it's challenging for me to get gas in my car to come to my appointments. So with that, wanted to pause here. I know we're at time. We're willing to stay on if anyone has any questions, thoughts, comments. Thank you for your time today. We appreciate you being here, and don't forget to claim your CEU.